Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we will be doing a demo demonstrating the procedure at clinic number 2. Just to recap on what we have done, in clinic number 1 we have finished the examination of the patient, and then we have made primary impressions. In lab number 1 we have asked the technician to pour those primary impressions and fabricate a primary cast. Then we asked the technician to make for us a special tray over that cast. Then the technician, once finishes his work, he will deliver it to your clinic. So what you'll have in your clinic are the following options. The technician might have made the special tray without any spacer. And if we're going to take a secondary impression without any spacer, this means the tray is closely in fit with the tissue. So the material will be, impression material, once we load it with impression material, this will be squeezed between the solid tray and the tissue. So when I'm taking an impression, it will be said that this impression is tissue compressive. The other option is that the technician might deliver the trays with a full spacer in place. This full spacer in place will be maintained until we finish what we call border molding. But once we want to take the impression, we're going to remove this spacer material. Removal of this spacer material will allow sufficient thickness of impression material. The impression material will not be pressed against the tissue a lot. It will be pressed, but with minor pressure. This minor pressure will not cause any displacement of the tissue, and this is called a mucostatic impression. So taking an impression, secondary impression, using a tray with a full spacer, this will be mucostatic impression. We said last week that totally mucostatic or totally mucocompressive situations on the long term are not beneficial to the patient, because in the mucocompressive status, immediately all of the tissue will be compressed inside the patient's mouth once we deliver a denture, because the denture will be delivered over a compressed tissue status. So the denture will immediately go to the compressed state. The problem is not all tissue can withstand such pressure, and then we will have problems of resorption, pain if the nerve is crushed, maybe a twitch or some uncomfortable feeling, trauma if we have thin mucosa. So the compressive status will cause problems on the short term and the long term. The mucostatic situation, if we deliver a denture fabricated while the tissue are in their resting position, by the time the denture will begin sinking into place, because these tissues are compressible, and we will have long borders along with the pressure delivered to the ridges, because the denture will, while in function, while biting on the denture, once this becomes a denture, the pressure applied over the basal seat area will compress the tissue beneath, because it is compressible, and we will have the borders hitting because they become longer as they are inserting more into the sulci, and then we will have on the long term the problems over the crest of the ridges and so on. So also we prefer not to select the tissue static impression. What we are doing is what we call selective pressure technique, meaning that I fabricate the tray in a way that I'm placing the spacer only over those areas that need relief. And we have discussed those areas: mid-palatine raphe, the rugae area, the crest of the ridges. If I have undercut areas with thin mucosa over them, these should be relieved. But otherwise, I'm exposing the tray to the compressible tissue that I am allowed to compress, because they have sufficient quality of bone, they have sufficient quality of mucosa over them, and they could withstand pressure for the long time, and this will prevent the resorption of the denture on the long term. So this is called selective pressure technique. So a partial spacer could be placed for this, or a tray that has been previously fully adapted to the cast. After we finish it, or while fabricating it, we make holes in it. These holes will act as pressure release areas where the impression material will escape through them, and so we will not have pressure on the areas where those holes are located. The only areas we will have pressure are those on the sides here. So this is called selective pressure technique. For your training purposes, we have asked you, one of you to do with selective pressure technique. We have asked you one to do the lower perforated and one student to do the partially relief of the upper. And you will be exposed to both experiences. So these are now delivered to the clinic. The first step in the clinic will be what we call border molding, and then we'll be talking about impression taking. So the trays have been delivered now from the technician. We have chosen the method of relief that we want for our patient, and these trays are ready to be checked inside the mouth. For this demonstration, we don't have the patient here, but what we usually do is that we check that the features that are present on the cast are also present inside the patient's mouth. Remember that we took a primary impression. That means in some areas we have not fully recorded the details of the basal seat area, and we need to take something more accurate. So we said that we need what we call a secondary impression. For the secondary impression to be done accurately, we try to concentrate on the borders first, and we take an impression of the borders only, and we call that border molding. And then we flow our zinc oxide eugenol over all of the border molding, and we do the secondary impression. So we have accurate reproduction of the borders first, and then we flow the impression material over the whole fitting surface or the basal seat area on the tissue and the fitting surface of the tray. So once we squeeze, we get all of the basal seat details of the soft tissue. So it's two-step stage. Border molding first, and then over it we take impressions. If you want to revise the first step, which is border molding, we need to check that the space we have on the cast is true inside the patient's mouth. So once we have delivered the trays and we find that all of their features are all there, the body is smooth, the outline of the cast on the cast is 2 millimeters away from the sulcus, they have a sufficient handle, the handle is vertically inclined in the first part, and then it rotates to the outside so the dentist can hold it. So once I finalize the checking of the lab work, I approve this to be done in the patient, and then the patients come in. I go back and check the tray inside the patient's mouth, because sometimes on the cast they look beautiful, but once inside the patient's mouth, some patients have hyperactive tissue. That means their tissue can move a lot around the denture area. So those people that have a lot of function around the denture border area, we might find that once inserting this inside the patient's mouth, that it might be hitting the sulcus rather than being 2 millimeters away from it. So inside the patient's mouth, I began checking that all of my borders are short than the patient's mouth. If any border is touching the sulcus inside the patient's mouth, I bring my bare and reduce it to make sure that the border is all continuous inside the patient's mouth. Once checked in the patient's mouth, now I'm ready to do border molding. For border molding step in the clinic, you will have from the dispensary what we call a green stick material. Green stick is a type of the compound. It's similar to the compound you have earlier in the primary impression. But this is a low fusing, meaning that at a lower temperature it will fuse and it will become playable at lower temperatures, so it's easier to manipulate than this type. This has more filler in it. So it's called the green stick. It's a type of impression compound. It has wax in it, and it has fillers, and it has, of course, the color which is produced, which is green. For your case, because this is a lab procedure, we don't have patients today, we're going to use your casts as the patient. These will demonstrate the patients now. So we're going to suppose that this is a patient, not a cast. So we want to make sure that compound does not stick to it. So we're going to paint the cast borders using a very minimal amount of Vaseline. Just minimal, very thin film, meaning that it's invisible. So if you look closely, you'll not see a layer of Vaseline there. It will only be a thin film of Vaseline painted on the areas where green stick will be touching. So once we finish, we are now ready to do border molding. When you were finishing the tray, we told you that we need some, not to adjust a lot of the border area. We just need it to be free from sharp edges. We need it to maintain rough because we're going to add a green stick. Make sure that the border does not have any Vaseline remnants or from your fingers or anywhere, because we need the green stick to stick to it. So we make sure that it's totally clean and free. If we have tried this in the patient's mouth, we wash away the saliva that might have stuck to it in the clinical case. We're going to add section by section. We're going to begin by the interior. This makes it easier for student training purposes. The way we heat our green stick is using a flame. And this is the dry flame. We heat the material and we go back and forth. This is what we call tempering. So we're heating slowly. If it drips on the surface, I'm going to stop to make sure that part of it is flowing. Now it's in a flowable status. And you might notice that it's shiny. This shininess comes from the components of wax that are present inside the mixture. This wax is has a low density, so once heated it goes out to the surface and becomes tacky. You can see that it is sticky. So I'm going to add first the interior border. Notice that in some areas I begin adding, but it's not sticky enough. This is when it cools down. This happens when it cools down. And this is not sufficient, because even if I spread it, it's still soft and it's spreadable, but it's not sticky to the tray. What I might face is that after adding all of this, it will simply fracture away because it had not adhered. It needs temperature to adhere. So I have added a bulk of material. I wet my fingers using water, and then I mold the border with the green stick. Anything that went to the buccal side, I remove it. Anything that went into the lingual side, I take it out. And I join the material together and make of it a roll. While once more I'm border molding or shaping the border just before taking it in the patient's mouth, I smooth the material. No additional creases are there, and not a lot of material is flowing to the outside, so we have the material ready. But while I had been finger manipulating it, it dried out and it cooled down. So it's not flexible enough to go into the patient's mouth. So we need to reheat it on the dry flame. What will happen is that the heating itself will melt part of the surface, and we get this shine. Can clearly see it. So it becomes smooth and shiny, but I don't go into the patient's mouth immediately. I go to the warm water just to cool it down, because it's much more hot than the material. The flame had produced the material very hot, so I went to put it in warm water to cool down a bit, but it's still playable, and I press it inside the patient's mouth. If I take it out, after it cools down, notice that it took an impression of the border, but in the same time it became matte. It's no longer shiny. Why did it become matte? Because it really touched all of the cast and the tissue inside the patient's mouth. And this is how I know that my material has reached the full depth of the sulcus. For the case of the cast, you cannot do anything further to the border. But in the case of the patient's mouth, when the tray is inside and I have tissue around, I begin manipulating the tissue and putting it into function. This manipulation of the tissue will shape the border, not in the resting position, but in the working position. So it's not only placing the border material inside the mouth, but also taking out the tissue and manipulating it and holding it, and as if I'm mimicking the oral functions that the patient does with his cheeks and lips. So this is called border molding. So I'm shaping the border of the tray using green stick material, taking an accurate record of the sulcus depth and width at function, not at rest. So that's why we need to do the border molding step. So I'm now ready to do the second section. So I'm tempering the green stick. I could cool it down, gather the material all together, because it will flow and drip. I want to just gather it and heat it as gathered material. I put it into flame once more and see how it's now flowing. And this flow comes once the heat reaches the core of the material. And I begin adding. If it doesn't stick instantly, I take it out and heat it. I want it to stick on its own. If it stops sticking, I heat it once more. Okay, it's sticking and it's flowing. And I stop here. Once more I cool my fingers and then shape it, gather it all together. Anything that went into the fitting surface, I take it out. Anything that went outside, I put it back. So I have a new border now. This new border is not corresponding with the patient's mouth. I have to have it as a copy from the patient's mouth. So I heat it. This is the final heat. Heating is shiny. I place it in warm water and then go into the patient's mouth and put it into place and squeeze. Then, if the patient's case, I hold the cheek and begin doing pushing the cheek downwards and pulling it to the inside and pulling it downwards, so I could record the functional depth of the sulcus. For the cast purpose, it's enough just to press by your finger, making sure that the green stick went into the sulcus inside. Now why do I border mold correctly? Because I had some space between the tray and the sulcus, so there is space for green stick. So it will border mold beautifully. Once more, if you look closely, you can find that the sulcus roll recorded in the impression, it's a continuous roll from the beginning till the end, where it ended. It's no longer shiny, it's matte, and that means it had touched the depth of the sulcus. So this is fully recorded now. So as we were looking in your primary impression, we were looking at the border and concentrating on the border, as you remember. I was asking all students to identify the borders of the sulcus. So here as well, we're looking for this continuous roll of material without a lot of excess on the buccal side and without any excess in the fitting surface area. So we have finished border this side, border molding this side. We're ready to do the other side. So once more tempering. I'm not heating till it's dripping, no. I am going in and out until the heat fuses into the core of the material. And once it's flowable, I make sure it's sticky, and if it's sticky, I begin adding it till the end. I cool it a bit with warm water and begin manipulating it with my fingers, making sure anything that went to the fitting surface, I'm pushing it out. So the fitting surface is clear minimal amount of green stick is there. And on the buccal side, there is no excess. And it's ready to be put in the patient's mouth. Before I do that, I give it a shine, giving it heat as well to be soft. Put it in warm water to cool down a bit, not to burn the patient, and then put it inside the patient's mouth and then border mold. On the cast, we're going to press it by our fingers, but in the patient's mouth, this is the upper, we're going to pull down the upper lip, go back and forth with it, and do this circular motion with the lip. So I hold the lip, put it down, and begin doing a circular motion. This will mimic the patient while he's whistling or blowing. The lip comes lower, and the sulcus itself comes shallower than the resting stage. So this is what we're recording. Once more, it's the functional depth and width of the sulcus. At function, of course, not at rest. So, once more, we have border molded the material, and the excess went to the outside. Continuing with the other side. If it stops sticking, I stop adding. I need it to stick totally. So it is sticking. I add until I have added a bulk of material. And even if it's irregular, let's suppose you have done it like this, as most students do, very irregular, put it in warm water. It's no longer sticky to my gloves. This is why I'm cooling it with the warm water. I'm gathering the material. Anything on the fitting surface, once more, I'm pushing it to the out. Anything on the buccal surface, I'm squeezing it on the border. Anything that is not attached or not sticky, I just remove it. I don't leave it because I don't want my material to be fractured later on. And a bit irregular, ready to be placed in the patient's mouth. I do the final shine, make sure it melts down a bit and becomes shiny. I cool it down in warm water. Somebody could be asking, why am I cooling it in warm water, not in cold water? If I cool it in cold water or regular room temperature water, it becomes hard. I lose the pliability of the material. I lose its flexibility. In the patient's case, this is the cheek area. I'll be taking the cheek downwards, pulling, for this is the upper, I'll be taking the cheek and pulling it down. And once I reach this to buccal angle, it has a different border molding procedure where I ask the patient to open maximally and go with his mandible to the left and right. This will record the area with the coronoid process close by, which is very close in this situation. Take it out, check. I see the continuous border all around. Now I have the roll all around the anterior and the posterior margins. I have done the functional movements of the lip and the cheeks. And by the way, when we border mold the area around a freni, we pull the cheek also in front and the back because these freni are muscular freni. They are composed of muscles. So these muscles, once pulled back and forth, these are the regular way of moving while in function. So remember, when you smile, your mouth opening becomes wider because these freni push the mouth to the side. So they have some lateral movement. So when I'm mimicking the movement over the border here, I would pull the cheek not only downwards but also sideways. So I have recorded the sulcus. Now we're going to do the posterior part. Notice that in many times while we are curing the light pure acrylic material, sometimes it shrinks away from its adaptation. Remember that we have placed a piece of opaque material to reduce this, but even though sometimes or many times we have this gap produced by the shrinkage of the material while polymerizing. So the cast sometimes is away from the tissue vertically. In the hamular areas, sometimes the tray is short, so we can extend with the green stick and cover the hamular areas. In the distobuccal angle area, we need to fill in with regular border molding. And here we ask the patient to open his mouth widely to border mold and record this sulcosat function. For the hamular area, we also ask the patient to open widely. So the muscles that are present here, which is the pterygomandibular raphe, will be stretched and will border mold this. And in here, we'll ask the patient either to swallow or to say ah, or do Heimlich maneuver, which is blowing the nose while it's closed. All of this will cause the soft palate here to move in a way that it records the functional movements of this soft palate. The way you are adding green stick to the posterior area would be the same up to the hamular area, but then we're going to add also on the fitting surface. We'll be telling you why in a moment. So I'm going to do my regular additions on the distobuccal angle of the upper. Stop sticking, I stop adding. How do I know it stops sticking? I keep pulling it away from the tray. So it's still sticking. But notice here, I'm putting it and taking it away and it's going out. It's not sticking, see? Even it's still flowable and it is workable, but it's not sticking. So if I add to this while it's like that, what will happen? It might fracture later on. So let's say that the first time I add, it's like a glue layer, and then the second time I'm adding bulk to it. So once more, the distobuccal angle, I heat it, I gather it, so whatever had flowed inside, outside, I make it as a roll, a beautiful roll. I remove the folds and the creases in the material. It's ready to be put in the patient's mouth. I add to it the final shine. I put it in warm water, and then I press it into place inside the patient's mouth. The patient, I would ask him to open maximally. And for this side, I ask him to move the mandible to the left and the right. What happens is, while the patient is moving the mandible to the left and the right, what we call the coronoid process will come close to this area, and it will border mold the width of the sulcus here. So, patients, I would ask him, please, can you please open your mouth maximally, go to the left and the right with your mandible, and this will border mold this area. So I'm still running on the same principle. On the distobuccal angle, I'm still going with the same principle. Now, if anything flows on the tuberosity, this is okay. Tuberosities can withstand pressure, and they are preferably compressed. So not bother if the material goes into the fitting surface in the tuberosity area, but I would bother if it comes in the anterior area. I'm going to add the other distobuccal angle. So once more, as long as it's sticking, I'm adding. If it doesn't stick, I don't add. And my second, so the first layer was the glue, and the second layer, I'm adding a bit more material to perform the bulk of it. Construct the bulk of it. So I'm putting it to a flame, cooling it down a bit with warm water, gathering the material, removing excess, rolling it into a beautiful roll form, giving the final shine, putting it back. Notice that I'm putting it a bit vertically here, not horizontal, because the hamular notches are deeper than the tray area. And let the patient open maximally and go with the mandel to the left and the right. The coronoid will come close here and border mold this way. Once it's cool enough, I could take it out, and I find that still the border is continuous now. If anything is on the fitting surface, I could simply take it away. I could heat my lacron carver. I could do it with a blade and make sure that the fitting surface here is clear. So I can do it at the beginning when I'm molding the material using my fingers, but I could also do it later once it cools down using a lacron carver. So it's now all away. Now, in the area in the middle, I not only add the material to the border, I'm also adding it onto the posterior part of the hard and soft palate, the firm soft palate, because we know this is the hard palate, but here there is the beginning of the soft palate, but it's still not mobile. This area is made of glandular tissue, so it's the posterior part of the palate that is not mobile. It's composed of glandular tissue in this area, especially in this one. And I'm going to use these glandular areas to do what we call a post dam. So an extra pressure over the fitting surface there is recommended. So to do that, I'm not only adding the material to the border as I'm doing the first glue step, let's say. I'm adding the first layer on the border itself. But the second layer, I'll be extending the pressure material or the border molding material to the hard palette, the non-mobile part of the soft palette. So I'm adding over the fitting surface of the tray here. Take away excess material. It's not looking beautiful, but once more I heat it, put it down a bit with warm water, mold it by my fingers, removing all of the excess, gathering the material by my fingers, spreading it, not in the mid part. I tried in the mid part to keep it on the fitting surface free of material. I spread it only on the both sides of the rafi, not in the middle. The middle I'm trying to reduce the amount of material on the fitting surface. So this is the compressible area, ready to be loaded in the patient's mouth. I warm it once more. Now because it's a bulk, I need to temper it for a longer period of time. I'm tempering it twice or 3 times until I'm sure that the material is flowable enough. And once ready, I cool it down in the warm water. I go into the patient's mouth and I press vertically first. And with my fingers, I could also go into the patient's mouth and further press this area towards the tissue. Okay. So now I have recorded the posterior part, and I've also asked the patient to say ah while I'm doing this step, and you can see that it took a copy of what we have on the cast. So I'm looking back at it. So anything in the middle, in the rafi area, I'm removing it. I'm leaving the part of the green stick on the fitting surface only on the lateral sides. Anything here, tuberosity areas, try to reduce it. And what I'm leaving is like a arch shape of material. I'm going to repress it inside the patient's mouth to finalize this area. So I'm removing excess that I think it's excess. I'm heating it once more, tempering it. Why am I going to repeat it? Because I want it as fine as possible. And this time I'm going to heat the whole posterior margin. This will take the final impression of the posterior area. So from this tubercle to this tubercle. Cool it down with warm water. This is where we need to apply pressure, firm pressure. Ask the patient to open widely. Say ah. Try to swallow a bit and go with the mandible from left to right. So, once it cools down, you could see where the material is added. Okay? On the sides of the rafi area, on the posterior part of the hard palate, and over the soft palate, the glandular tissue of the attached soft palate. So this is border molding ready. We check for its sufficiency in the patient's mouth, but after everything has cooled down, I've noticed that the borders are all there, continuous. The freni, labial frenum and buccal freni are clearly imprinted on the borders. The palatal area is covered, I go inside the patient's mouth and then try to remove it and check its retention. So if it has a good suction into place inside the patient's mouth and I could not easily remove it, that means we have what we call a border seal. And this is one of the features of a correctly border molded tray, that is stuck in place, not by the green stick, but by the suction. Once we squeeze on it, the tray will extrude under pressure. All of the air bubbles in between the two surfaces will be pushed away. And what we will have is a thin film of saliva and the tray and the borders sealed very well. So they act as a suction cup. So the tray is easily adapted to the patient, pressed into place, and then it becomes retentive. That's what we call seal, border seal. Now, if I have a perforated tray, because air can go through the holes, this is why we need to add utility wax before we add the green stick in the very beginning, where we said that if we have holes ready for us in the tray, just cover them with the utility wax before you do the border molding step to make sure that air does not go from inside. So once I want to perform the function of, or the test of suction, it will become positive here. But with holes, the air will come through the holes. So just to make sure that we now understand what is the seal. Denture seal. All around the green stick has taken a correct impression of tissue at function and is totally sealed. Some of you will be doing the lower. The lower is basically the same procedure. Before I begin, I spray the resin, paint it on the cast very thinly. In the patient's mouth, the material will not stick to the patient's mucosa because saliva is there. But in our case, it's a cast, a dry cast, that will mimic a patient, so we're adding Vaseline. We will check the tray inside the patient's mouth, make sure we have space all around for the green border molding material. We're going to do the same steps that we have done in the first time. Tempering, adding the first layer, which acts as a glue. Once it stops sticking, I stop adding. I would consider this a glue area. Stop sticking, stop adding. And this time I'm going to do larger sections. That's because you have understood the idea. But what will differ here are what we will be doing to the patient while we're doing the border molding. So all of the technical part is the same. I'm just adding now the second layer to add a bulk to the green stick all around. Cool it a bit with water. Use my fingers to manipulate it. Same as when you were adding utility wax. Do you remember when you were adding utility wax? We brought the utility wax and began pressing it into location. So as if I'm doing it with utility wax. Anything on the fitting surface I remove. More hand shaping, finger shaping of the border, make it more uniform. And once I feel it's suitable to be placed in the patient's mouth, I heat for the final time. I make sure that it's thoroughly heated. Cool it down a bit with warm water. Go into the patient's mouth and press. into place. What I'm going to ask the patient to do is try to blow his lips, or if I would pull the lower lip up and to the sides. I would take the cheek up on this side, the cheek up on this side, and laterally to border move this area. The distobuccal angle, I add it in the same manner, but the instruction given to the patient is different. I'll be asking the patient to open widely and go from left to right. But this is for a different reason. We were going left to right in the upper because we had the case where we had the coronoid coming close to the border area. For the lower, it's different. It's the same movement, but a different reason. In this area, which is the external oblique area, we have where the masseter is attached, masseter muscle. The masseter, once we press or go with our mouths to the left and right, the mandible to the left and right, this muscle is stretched. Or when we open maximally, this stretching of the material will cause the border to be molded perfectly. So, once more, the instruction to the patient, go from left to right and open maximally. But the reason is different. It's because we are on the masseteric plane area. For the lower, we need to record the full retromolar pad region. So, if there is wax, we could remove it. And we want to compress the retromolar pad. And we're going to record it all together. But when we make the denture will not be engaging all the retromolar pad. We make our impressions a bit longer than the area we're going to use in the patient's mouth for the denture. Why? Because we want to make sure that all landmarks are included. So in the retromolar pad area, I'm allowed to add the green stick on the fitting surface together with the area, the posterior. Heat, give it a shine, cool it down a bit, go into the patient's mouth, and the instruction here is to open widely. The same thing, the trigomandibular raphe muscle here will be stretched and it will mold the border in the posterior area. And the pressure applied on the retromolar pad will take it in a compressed status. It is made of glandular tissue and a fatty pad inside, so fatty tissue as well. So it's compressible, and this utilization of this function is good. So this is retromolar pad. Now we go into the lingual pouch. Let me just finish the left side, the other side. It's my left, but the patient's right. Okay. Add in the green stick material. To the border. Heat. Cool it down a bit with warm water. Manipulate it with my finger, shaping it. Giving it the final brush of heat. Cool it down in warm water and go to the patient's mouth. Press it into location. Asking the patient to open widely. Open widely, please. Go to the left and right with your mandible and taking out excess, in my case here. Now we're reaching where we're talking about the lingual pouch area. The lingual pouch area is a special area in the lower. It is the area on the distal end of the ridge, and if the tongue was here, it will be on the distal or the base of the tongue area. It's close to the base of the tongue. This area is deep. It's deeper than the buccal. And it is the main area that provides retention for denture. So we need to record it well. So we're going to add in the same manner. The addition, in terms of addition, we're going to add the same way, but the instructions to the patients are different. So lingual pouch area, I add green stick. So the first layer is a glue. If it stops sticking, I stop adding. I add a bulk to the material. Heat it, manipulate it by my fingers, gathering the material together, making sure nothing goes to the fitting surface. Anything on the fitting surface, I remove it. I gather it all together. But look how am I building the material. You remember that some of you faced the problem where the compound did not go into the lingual sulcus. So this is how we force the material to go into the location we want. We build it vertically. So this is lingual pouch built. The lingual pouch has a posterior part, middle part, and anterior part to it. Each part has a different instruction, so I'll put it in the patient's mouth. Ask the patient to do the following. First of all, to open maximally. Then protrude the tongue as much as possible anteriorly. This will press this side where the glossopharyngeal muscle works. Swallowing will activate this part, which is the deepest part of the lingual pouch. Moving the tongue to the left and right and swallowing will activate this anterior part. So if the patient does these, I would have recorded the lingual pouch perfectly. On the other side, so one by one, drawing out the border, going with the sticky layer first, adding a bulk of material here. So I add a bulk. I need sufficient amount of material here. Warm it up, or cooling it down, which is the actual case. Using warm water, I build my material, gather the material by my fingers, shape it vertically, give it the final shine, cool it down in warm water, putting it in the patient's mouth. While I'm in the patient's mouth, I ask the patient to raise his tongue while I'm putting it. I squeeze it first into place, ask the patient to protrude his tongue. It will activate this muscle here, glossopharyngeal. Say ick forcefully or swallow. It will activate the deepest part and the anterior part of the lingual pouch. So these are now manipulated and the sulcus is recorded there. This is excess material. I could simply just remove it by a heated instrument going down here, and I only leave the material inside the sulcus. I don't want excess material. I could repeat, go in, warm it, and press it into place, and this is the lingual pouch recorded on both sides. More of excess material. So removing the bulk of excess material on the sides would allow the material to flow, the excess material to flow away from the sulcus while under function. So this is the role of the impression all around. Lingual side, which is from 6 to 6. This is where the mylohyoid muscle acts, which is the muscle of the base of the mouth, or floor of the mouth, constructing the floor of the mouth. It has glandular tissue, it has the salivary glands in it, so multiple structures. This could easily be molded by asking the patient to move his tongue to the left and right, and then ask the patient to move his tongue posteriorly. So this will border mold this area. So, added the border molding material, gathered it together, tried to remove the excess, heat it, make it shine, put it back in warm water, and then press inside the patient's mouth. And I asked the patient to please protrude your tongue. Go back with the tongue, so touch with your tongue the palate, the hard palate, backwards, and move the tongue to the left and right. Left and right will stretch the muscle of the left and right areas. Moving the tongue backwards will reduce the length of the material. Moving the tongue forward would reduce the thickness of the sulcus. So these are the border movements from the lingual border from 6 to 6. So once more, protrude the tongue, it would reduce the thickness of the material. Go with the tongue to the left and right, it will reduce the sulcus depth here. Pushing the tongue against the palate in the posterior part, this will mold the length of the anterior area. So the lingual frenum will be stretched. And if I invert this and take it out, I could find that the border now is continuous from left to right, which I have now recording the cast, but in the patient's map, I would have finished recording the functional depth of the cast. Any excess of the material, I just take it away using the blade, making sure that my material is uniform all around. Any excess material from any side, I remove it. So you can notice now that the material is following the depth and width of the sulcus all around without an excess material. The continuous roll is all present all around. I could do a final border molding, just heating everything up on all the borders, just a quick one. Go into warm water and do my final squeeze all over the tissue. And in the patient's mouth, I'm going to give them all instructions at once. Please blow your lips. Go with your lips to the left and right. Open maximally. Go with your mandible to the left and right. Open maximally. Say ick. Swallow. Put your tongue to the left and the right inside your mouth. Protrude the tongue and go backwards with your tongue as much as you can, touching the palate. And that's the lower border molding finished from the patient's mouth. And now we are ready to take secondary impressions. This will be the work for today. Those that have a lower impression are going to border mold the lower. Those of you that have an upper impression, they're going to border mold the upper tray. And then we're going to go to the next step, next lab, where we're going to take impressions and do the boxing. Thank you. So once the material is extruded, we try to gather the material together. Joining the two plates. And we begin mixing until the material becomes uniform in color. We could first mix them. And then we begin squeezing them towards the pad. Spreading them on the pad and squeezing them, and then gathering the material once more. We'll take up any material that has not been mixed and we further mix it. So further mixing, and then spreading. until all of the material becomes uniform in color. And this is ready now to dispense inside the tray. For the upper tray, we're going to wipe the material over the surface. So we're going to spread it into the posterior parts, middle parts. We have to make sure that the material flows around the sulcus. So we want to make sure that the material flows on all sides. We spread the material, making sure it has even thickness all around. We cover all of the sulci with the impression material. And now we're ready to take the impression. Zinc oxide eugenol has a good working time, and it's reasonable to be working with it for you as students. And then we're going to apply it over the cast that has Vaseline. So if it was the patient's mouth, we will first seat the tray in place. We squeeze first from the back to front. What will happen is, once we squeeze from the back to front, we will have less excess material posteriorly, and we will have the excess come from anterior. Remember the rule that we maintain pressure all through the setting of the material. We maintain pressure over the tissue, and at this stage we let the patient do all of the border movements all together. We first tell them, do like a whistling, so he will be sending his lip and stretching the lip. Go smile from side to side and switch the mouth from side to side. We will be holding the cheek and pulling it down and rubbing it sidewise. We will be telling them, go with the mandible to the left and the right, say ah, try to swallow, and open maximally, and do all of the border movements on the other side as well. So while waiting for the material to set, we need to do border molding movements inside the patient's mouth. We need to test that it's set. So we do our finger test, where we, with our fingernail, we just press into the impression. If my fingernail leaves no mark, that means the impression is set. Also, I could use as an indicator, I could use the spatula material. If the material is set here, definitely it's in the mouth more set, because the mouth is more worn. So we make sure that the material is set before we remove it from the patient's mouth. So the material now is set. We have done all of the border movements inside the patient's mouth. Now we're ready to take it out. In the patient's mouth, because of the presence of saliva, removing it might be a bit easier from what we're going to do now. But on the cast, we have to just squeeze it and press it outside until we separate it from the cast. Vaseline here helps us to separate it. Notice that the impression should be checked for quality. What is the quality we check for impressions? We're checking to have a continuous roll of material in the sulci. We check that we have the anatomy clear, so I could see the buccal freni notches here, have left notches here. The labial frenum has left a notch here, the buccal freni here. The surface had recorded the rugae area, the tuberosity areas, they are the same as in the patient's mouth. A very small bubble is acceptable. The hamular notches are well recorded and clear on the impression. I could add a step in the patient's mouth. Suppose I have the patient is here. I also could measure what we call the buccal pouch. So I go with my finger in to the buccal pouch and record how much this length is, and then come to the cast opposite to the side, because this buccal pouch corresponds with this side. I go back to the impression and use that measurement and measure. So it will tell me, did I go into the full depth of this sulcus or not? So I'm pressing inside the patient's mouth, I take a measurement, I compare it with the area corresponding with that, and I find that I have recorded it. If I have found that my finger goes in here more than here, that means it's under-recorded. So what I could do in the patient's mouth, I could add green stick border molding material to fill in this space. So this is the check we do. The surface is continuous. My minute bubbles are acceptable. If larger than this, I might correct it using some green stick, add a bit of green stick, put it back into the patient's mouth and press it, and come back and remove any excess on the fitting surface. This might be sufficient. If it's larger than that, we need to repeat the impression. If sulci are not present, if it's only on the length of the sulcus, we could add a green stick. If it's on the sulcus and some of the structures here, it's better to repeat the impression. So the cases where we have what we call high vault, patients that have a palate very deep, might also have a big bubble here. We could add impression material inside the patient's mouth on the palate before loading the tray. So that's done with people with a very high vault palate. So we make sure that our impression is perfect, and this is ready to be disinfected and sent to the lab. Zinc oxide eugenol is a material that is stable. It could withstand soaking in disinfected materials, and we disinfect it in a medium strength disinfectant, and we could soak it there. For the lower, I'm going to extrude the material in lines. Want sufficient material. Gather the material together. First mix it, spread it, gather, spread. We collect the impression material, load it in the lower tray. Going to wipe it into place. We make sure that we spread the material over the borders. We should have all the sulci covered. We also make sure we're going in and out. We want to make sure that the floor of the tray is filled correctly. We fill on all of the borders. Make sure that the sulci will have sufficient material by covering all of the flange that will go into the sulcus, especially the lingual flange, where usually we have a lot of space in the lingual pouch area. Okay, so the material is loaded. We center it over the cast that has been applied with Vaseline. We first seat into location before pressing. We make sure that we are correctly located. And what I want you to really look closely at, see how once I begin squeezing, we begin squeezing usually the impression material from back to front. I want you to see how the zinc oxide eugenol is squeezed out of the hole areas. See how it's going out of the holes? Okay. This reduces pressure on these areas. And then once we finish, we just keep maintaining the pressure, and once in place, we begin asking the patient to do his border movements. So, for the patient, we say, blow your mouth, go with the sides of your lips from side to side. We hold the cheek and trim it like this. We also hold the posterior cheek and pull it upwards and trim it. We ask the patient to open widely, to go with his mandible to the left and right. We ask him to mimic the swallowing or say ick forcefully. This would raise this area. And then move the tongue from the left to the right and to front and to the back. This will mold this area. So all of these movements, we do them in the impression as we have done them in the border molding. We have many students asking that we have already done those movements in the border molding. Why repeat them in the impression? That's because once the patient goes back to rest, the sulcus depth goes back to go into its deepest location. This deepest location is not the one that will stay all the time while the patient is in function. What will happen is the denture might be overextended, and if the patient does a movement with his lips or cheeks, the denture will be taken out. So we make sure we record the functional depth, not the resting depth of the sulcus. We maintain our pressure and do our finger test. After we have finished all the border movements and the impression material is now set, I'm doing the test by my fingernail. I can take it out of the patient's mouth, and we could find that we have the material all around continuously. We have the sulcus continuously recorded all around, extending to the full depth inside the lingual pouch. If I had the patient here, I would take a measurement with my finger into the lingual pouch and see have I recorded this or not. If I have an area where we call a pressure spot, like this, the only area here recorded, I could mark it with indelible pencil. This pencil will copy itself into the cast once it's poured, and I just make sure that the denture here should not press on this, and I record this area. I have a bubble or discontinuity here at this site. So, what is good about compound material, primary or border molding material, that it's reversible, and I could correct it easily. So I'm simply filling it in this area where it was deficient. Heating it. Pouring it in warm water, pressing it, and then pressing once more with my fingers, spreading the material into location. Leave it to dry a bit, go out. See now that no longer I have the void here. It's now missing. I have filled it in with the addition of the green stick. Now I want to show you what might happen sometimes while you're border molding. If you could look closely there, you find that this area did record the sulcus well, while this area is still deficient and irregular, and the shining of the material that we have produced by the flame is still there. This means that the green stick did not touch the sulcus area. So, I'm going to add more material, and this is what once more is beautiful about compound, that it's reversible. I could add, I could remove, and it's a very flexible material to manipulate in the dental clinic. Okay. So the material was deficient in the first time. I added more material. Lower sulcus is a bit tricky sometimes because it is thin in comparison with the upper. So, ask the patient to raise the lip, go back left and right. I will hold the cheek and pull it up, and to the left and the right. On the cast, we just manipulate it by my fingers, pressing it toward the sulcus, and then checking the border. Now you notice that the roll of material is now continuous around the border. Any excess that went on the buccal surface, we could easily remove it using the lacquer cover. So once more we heat our instrument, we remove the excess here. Because if we don't remove it, sometimes this excess material on the buccal side or labial side might prevent the material to flow away from areas where it is long. So we just remove the excess. I would heat it once more. Go inside the patient's mouth and further press. And this is why it's called border molding, because the border will be shaping the green stick in its location. Okay, so now I have a continuous border here. But look at the border at this side. It also needs addition. It's irregular and it's not continuous. Once more. To fuse the old and new green stick material, I could heat this as well. It will become also sticky. I add now my new bulk of material over the border. So the first layer will act as a glue, the second layer will add the bulk. I heat it, give it a shine, put it in warm water to cool it down a bit, and then place it in place. I'll ask the patient to raise his lip, lower lip, or I will pull it and go back and forth, left and right. In the cheek, I'll be pulling the cheek out and going to the left and the right. And once it cools down, now I have the roll continuous in the anterior area. To show you common mistakes that we might have with impressions that we have done, you might find the following problems. For example, here we have a good sulcus. Suddenly the sulcus discontinues. The material here has not been squeezed enough into place, or the material was deficient. If we go to this side, also this side, we have deficiency of impression material. How did I know? The roll of the sulcus, the beautiful round cross section of the sulcus, discontinues here. It becomes very irregular, and creased lines appear in the material. So this is a deficient area in recording. This is what we call pressure spot, where green stick shows through the impression material. And this pressure spot is one of the mistakes, where green stick was extending into the fitting surface. Once more, the sulcus here is not continuous. The roll is missing, so the lingual side needs more material to be put in. And we have another pressure spot here. So this impression might have, while inserting it, did not fully seat into location. Put it in warm water. It's no longer sticky to my gloves. This is why I'm cooling it with the warm water. I'm gathering the material. Anything on the fitting surface, once more, I'm pushing it to the out. Anything on the buccal surface, I'm squeezing it on the border. Anything that is not attached or not sticky, I just remove it. I don't leave it, because I don't want my material to be fractured later on. And a bit irregular, ready to be placed in the patient's mouth. I do the final shine, make sure it melts down a bit and becomes shiny. I cool it down in warm water to separate it. Notice that the impression should be checked for quality. What is the quality we check for impressions? We're checking to have a continuous roll of material in the sulci. We check that we have the anatomy clear, so I could see the buccal freni notches here, have left notches here. The labial frenum has left a notch here, the buccal freni here. The surface had recorded the rugy area, the tuberosity areas, they are the same as in the patient's mouth. A very small bubble is acceptable. The hamular notches are well recorded and clear on the impression. I could add a step in the patient's mouth. Suppose I have a patient, the patient is here. I also could measure what we call the buccal pouch. So I go with my finger in to the buccal pouch and record how much this length is, and then come to the cast opposite to the side, because this buccal pouch corresponds with this side. I go back to the impression and use that measurement and measure. So it will tell me, did I go into the full depth of this sulcus or not? So I'm pressing inside the patient's mouth, I take a measurement, I compare it with the area corresponding with that, and I find that I have recorded it. If I have found that my finger goes in here more than here, that means it's under-recorded. So what I could do in the patient's mouth, I could add green stick border molding material to fill in this space. So this is the check we do. The surface is continuous. My minute bubbles are acceptable. If larger than this, I might correct it using some green stick, add a bit of green stick, put it back into the patient's mouth and press it, and come back and remove any excess on the fitting surface. This might be sufficient. If it's larger than that, we need to repeat the impression. If sulci are not present, if it's only on the length of the sulcus, we could add a green stick. If it's on the sulcus and some of the structures here, it's better to repeat the impression. So the cases where we have what we call high vault, patients that have a palate very deep, might also have a big bubble here. We could add impression material inside the patient's mouth on the palate before loading the tray. So that's done with people with a very high vault palate. So we make sure that our impression is perfect, and this is ready to be disinfected and sent to the lab. Zinc oxide eugenol is a material that is stable. It could withstand the soaking in disinfected materials, and we disinfect it in a medium strength disinfectant, and we could soak it there.